Oh, hi, I'm Anton Pozniak, and I'm really pleased to be with Kate. It was a great session. I really enjoyed all the talks, and I think you did marvelous to condense them down into these small sections. One of the themes I saw running through this was the role of healthcare workers and probably into getting differentiated care, but also skilling them up in terms of what they could do in the future so that we can provide great services. Now, we've had some questions in. The first one was to Jean. So Jean, it was around a traditional healer issue. You were mentioning about traditional healers and transmission. It was really wanted to know whether or not these traditional healers, whether there was a differential in terms of what they transmitted, and whether they contributed greatly to the actual incidents that was going on. I don't know if we've got Jean there. Jean, can you hear me? Hi, Kate. I don't know if Jean can hear me. Okay, well, maybe I can move on then to Moses. Moses, can you hear me?
Yes, I can hear you.
Oh, hi, Moses. Yeah, it was the factors that contributed to mental health disorders in the young. Apart from stigma, did you look at other factors that might have contributed?
Yes, we did collect a wide range of data across the social demographic, psychosocial, but also HIV-related characteristics of these young people, and applying the multivariate logistic regression analysis. Some factors made it to the final model, which I presented. Yeah, so apart from stigma, there were quite a range of other variables that we did look at.
Okay, that's good. So I hope that's answered that question. There's quite a few questions around the drug resistance. I was quite interested actually by this, and I wondered that. So just quickly, whether or not you think there's going to be an impact by the rollout of dolutegravir in terms of transmitted drug resistance. I don't know how long dolutegravir Mulugeta has been rolled out in your country. Mulugeta, you're not there?
Yeah, I'm here.
Coming on. Oh, hi. Good to hear you. Do you think there's going to be, has dolutegravir been rolled out for a long time?
It's started back in 2018.
Okay, so
after
maybe
we take sample.
Okay, so maybe okay, all right. So maybe that you haven't seen the impact of that at the moment on the transmitted drug resistance.
Yeah, we didn't see. We have taken the samples. It's on the way. We are working on that, on the integrase resistance.
Okay, so there's a couple of things. One is the antiviral resistance by drug class that's been asked. Have you differentiated by drug class in your
yeah, in our analysis? Yeah, yes, we did.
Do you know any of the results off by heart, or perhaps we could contact you for those?
Sorry?
Do you know any of the data about sulfur?
Yes, I had the data, and the higher percentage is the higher percentage was in RTI-associated drug resistance.
Okay.
And the PI were the lowest.
The lowest, yeah, and that sort of mimics what most countries in the world have seen, isn't it?
Yes.
And quickly, it says resistance with 9.8 prevalence as per your data. Is that a big burden compared to the cost implications?
Yeah, it might not be, but the thing is, we need some kind of national study to come up with the clear picture of the drug resistance. And we believe it might be increasing. You know, the presence of the absence of drug resistance testing along with the poor adherence, it might be more than 9.8. So due to this, we recommend the drug resistance testing to start.
Okay, thanks. Thanks for that. So, yeah, and I think that drug surveillance, of course, WHO have put a big stock on that. It's crucially important, especially now with the rollout of the dolutegravir through all the countries. So we must keep our eye on this. Caroline, I just want to talk to you, if you don't mind, ask you a question. Is that, do you have very much differentiated care where you're working in Mozambique? Because it seemed to me that 1.7 to 4 hours in a facility is a sort of when I worked in Africa and Zimbabwe, that's the sort of what happened when you come to the clinic, you know, and see the doctor. It's 1.7 to 4 hours. Whereas if you have differentiated care and you're out in the community, etc., and having local clinics, that it's much less than that.
Yes, so we do have differentiated care models. The first one is the community adherence support groups that has been there for quite some years now. More recently, the 3-monthly drug dispensation has been introduced. 6 monthly is very recent, since last year, but well, this year with COVID, everything changed a little bit. So yes, there were some models even during the study period that were already implemented. But just to mention that the 1.7 hours, that's the first quartile. So that means most of them are longer. And so yeah, it seems short, but even we actually had a qualitative component, and there we really saw that people really waited long times. And so yeah, but you're right.
Yeah, so I think I'd like just to go to actually keep on that subject with you, Kate, about the fact that people who are close to a clinic, they seem to take this up better. And I wondered whether, again, if this was rolled out to differentiated care systems, you'd see a different result, rather than having to travel to hospitals or even different facilities to get this NCD treatment.
I mean, that's quite possible. I do think proximity helps. Also, it really depends on the person. I think there's a lot of psychosocial barriers that still need to be addressed, as well as it depends on the clinic themselves and how much of a kind of a disease burden that facility is combating. Okay.
And now Natella, you were saying about skilling up healthcare workers for managing virological failure. Could you just expand a little bit on what you think they could provide?
Thank you, Anton. I would like to comment on that. Thank you very much for opportunity to raise it. I think the major challenge we are hearing is that we frequently hear the rates of viral suppression either at regional facility, district level, but we really want to get to the point where on the level of each medical record, there is a clear recognition of virological failure, not just documentation at the numbers of 80% suppression. We are focusing on those who are 20 or 15% non-suppressed, and there is a clear multidisciplinary team review of the chart. And what most important, and what I try to reflect in the workshop summary, is there is a timeline established that is followed for the outcome of intervention. So pretty much introducing the model where not putting all that burden on the shoulders of healthcare worker providers who are very busy, but really building up the structure of multidisciplinary support and establishing the system of tracking what happens. We all know enhanced adherence counseling exists, but we, through the especially New Horizons Collaborative, which I try to reflect, see children who are on the PI failing regimens, sometimes 18 months to 24 months without really any improvement. And when you look at the viral loads, they remain high. So what we are doing is pretty much harboring more in RTI resistances, and there are such a good opportunities for change right now. So in summary, trying to make sure that viral load result is taking at the patient record level, and the multidisciplinary team of providers, which is broader than just healthcare worker himself or prescriber, addresses this in a timely fashion. And we have developed some tools. I don't want to take too much time, but we did develop a tool for the treatment failure management with an algorithm for steps to take. So we are trying to scale up the tool across the country in collaboratives.
Oh, that's amazing. That's amazing. That's great. Thank you for that. Fabienne, about the pros, I just wondered that where were the pros developed? Are they developed specifically for an African setting that you did? Because, you know, it may be that you could do patient-related outcomes in Asia and the outcomes might look different to those in America and to Africa. So are they validated for African settings?
Yes, for health-related quality of life, we used the SF12 questionnaire, which has been developed in northern countries, but has been also used successfully in the African setting. And by contrast, the scales that we use to monitor fatigue and self-reported symptoms were developed in northern countries. But I think that as we looked for a list of symptoms, it applies both for in every context, I think.
Yeah. Well, thanks for that. It's very reassuring. We've Jean, I just want to come back to you about resistance and about hepatitis, and it seems that you have a good program for vaccination. And I'm only raising this because one of the things that's coming is injectable antiretrovirals, long-lasting injectables. And obviously, the combination that we have at the moment, the cabotegravir rilpivirine, you'd have to really check that somebody's not got active hepatitis B, because obviously you're not treating the Hep B with that regimen. But it seems to me that your rates of Hep B are extremely low because of your vaccination program. And I just wondered whether you want to reflect on other parts of Africa, like Zimbabwe, where there's over 20% Hep B, and other countries. And how long have you had the program for, do you know? And because it seems to be extremely successful.
Yeah, thank you very much. I can say that for the low prevalence is not due to vaccination, because vaccination, the high coverage of vaccination for hepatitis B is among children who were born after 2022, meaning that it is for 18 and above and below. For people who were born before, they are not protected as that. And I think we do not have the prevalence of hepatitis B, which is high comparably to other countries. I don't know why, but I think the transmission, how transmission can be done is different from other countries. You know that the hepatitis transmission is mainly transmitted through through mother to child, and in our country, I think it was not like this. We didn't have much like that, and I think because of that we have the low prevalence of hepatitis B. Yeah.
Oh yeah. Okay. Well, that's very interesting, actually, because I wonder whether that's similar to other places, and I suppose that needs looking into, because if these drugs are being rolled out, some parallel plan in countries that don't have a lot of hepatitis B immunity needs to be given. But it seems to me it's for 0.01% in your country of Hep B. If you're going to give these drugs, it's probably not cost effective to do a lot of screening. But we'll wait to see. Apollo, your IPT study, it was quite amazing how you went from 32 to 97%. Have you looked at the resource implications of this, or do you think that the actual incremental cost of doing this was very small because the patients were already there? I don't know if you can hear me, Apollo.
beg your pardon. I think I didn't get the question.
Oh yeah, okay. I'm saying,
Can you
first
please
of all,
repeat the
congratulations.
question, Anton?
Yeah. Can you hear me now? Can you hear me?
Yes, I can hear you.
Yeah. Right.
Yes.
It's really congratulations, first of all. A very, very good effort. Really fantastic. And secondly, the incremental cost of doing this, was that mitigated by the fact that the patients were already there and ready to receive it, and it was all organized? Or did you have to put in a lot of manpower and a lot of resource to get to the 97%?
Okay, thank you so much, Anton, for that question. So basically, we used the already existing structures. So the healthcare workers were already there, the coaching support system was there, and the patients were already there. So we just implemented some change ideas just to improve on that gap that was identified. So some of the things that were implemented included, for example, data cleaning and validation. It included using of reminder systems, using of stickers, on the patient care booklets, using of TPT, TB preventative therapy stamps, and also making sure that the teams are coming together at a facility level, the quality improvement teams. Every month they are coming together, they are looking at their data, identifying gaps, and also coming up with interventions to improve on those gaps. So already existing structures were used, so there were no really big added costs. The only cost I may say was for the learning sessions. This is where now different facilities were coming together to share and learn from one another. But apart from that, it was already the existing structures. Thank you.
No, that's fantastic. Wow. Congratulations again. I think it's a great achievement. And now I think we've got time for one or two quick questions. Kate, I was very interested about this. What's the other Kate? Yeah. I just wondered whether or not some of the patients where they were asked to have their NCDs referred and they felt that it wasn't the province of the doctor they were seeing or the healthcare worker they were seeing at the time, that it was a sort of, they looked at it as a separate problem for themselves and it wasn't all integrated. And so it was basically self-perception rather than perception from us. And when you've looked at that.
We don't have data from that. That would need to be, a further investigation. But I do think there is evidence out there in other studies that your perception of your own health determines whether you will want to link to care or not. So even though we did find a lot of patients with risk factors for chronic disease, they might have felt healthy and might not have wanted to link to care. Or, I feel like there's a lot more information out there about, say, TB or HIV, and NCDs are largely left kind of behind or not prioritized. And so I think there's an educational component to that too. Yeah.
No, that's certainly true. And I think that as our HIV patients are getting older and older, the work that you've done is going to become more and more important, because we'll have so many people living a healthy life, but with comorbidities that need to be checked. And I mean, the data from the UK is that the males are living longer with HIV than they are without HIV, because the males with HIV get screened for diabetes, prostate cancer, all this stuff, and it gets picked up earlier. So there you go. All right. So I think we're coming to the end of the session now. I'd like to thank my co-chair Kate for a wonderful conference and all her efforts and work in this, and for this chairing this presentation, and for all of you for your time and all your wonderful research. And I really wish you all well in the future and good luck. And I look forward to reading all this in print. Thank you very much indeed, even virtually. Okay, bye now. Bye.
Bye, everybody. Thanks.
Bye.